you very much all for joining. I hope you can see me and hear me clearly. So today I'm doing a session for AMC Clinical exam. And those of you who have watched my career guidance session videos, you know that I put very much emphasis on the AMC Clinical exam, and that too for a good reason. I believe that AMC Clinical exam is an unofficial requirement almost for the people who've got career gaps to start their careers here in Australia. There's no confusion about it. It's a very factual statement that I'm giving you because I've seen many doctors who are working with me in the recent times. They have actually passed the AMC clinical. Now, previously things were different. The doctors who got jobs about a year, 2 years ago, for them AMC1 is fine. They may have good CVs, they may have no career gaps. That's why they did not, require AMC clinical. But now I think with increasing competition, and as I said, that if you've got a large career gap on your CV, then AMC clinical reassures the employers about, giving you a job. That does not mean that people with AMC1 are not going to get shortlisted. Obviously, you're going to get shortlisted. But I'm just saying that if you want to improve your chances in a very factual and realistic way, then do consider AMC Clinical. So, what I'm going to do is I've actually made some AMC Clinical scenario based on the recent recalls. Uh, I'm going to, as I said, case cases are very simple. We're going to organize that as a cluster-based approach. How should you prepare for any particular cluster, which are important? And these clusters which I've done today are based on the um, recent recalls. So clusters are good because they help you remain organized no matter how much pressure you're in. And that is especially pertaining to your history, examination, and obviously lots of these stations involve quite a lot of communication, counseling, breaking bad news. So I think the cluster will keep you organized. My rule is 3C rule. You need to remain relevant because often when people are following clusters, they lose their relevance. They become descriptive. They just try being very formulaic, which does not help you because if you go formulaic, if you become detailed, then you lose your command of how to deal with the patient. You also need to be complete in terms of doing the task. There is no point that you're doing everything and you're not complete. And especially the task, it may requires you to take an adequate history of pain. And if you're not dissecting each and every component of pain, then you might be in a bit of a trouble. Um, I've got one dizzy scenario, and if you're not really excluding the red flag for dizziness in terms of, central versus peripheral causes versus ENT causes versus cardiovascular causes, then it's not complete. And no matter how thorough your cluster is, it's not going to get you across. And lastly, clear communication is something which is weighted very heavily in this exam. And I'll tell you what it means precisely, because whenever I talk about clear communication, people often tend to get confused. But in essence, the bottom line, if I want you to take away anything from this session, clear communication means when you're talking to the patient, you're talking in a way that the patient can understand. It's a layman term. It's you as a parent explaining to your 5-year-old, as a parent explaining to your 10-year-old, or as a doctor explaining to a little child. So if you can become clear and have a clarity of a very complex condition and able to do that consistently, trust me, you will not fail the communication aspect of any station. Now, we'll move on. Next thing up is the time management. And the time management, as you know, it's 2 minutes of reading time. You get about 8 minutes of performance time, give or take. And now what AMC does is that you may have clear distinction in terms of, you may have to take a history for 4 minutes, then come up with a diagnosis. And I think it's good to talk about a diagnosis, that how you've reached the diagnosis, and then give a certain explanation around it, which may take another 4 minutes, diagnosis and explanation. And I think the important thing when you're doing the time management, you need to stick to the task. You cannot go, you know, tangent into something which are not required, thinking that you're scoring mask. And of particular thing which I've seen consistently people making a mistake, they do not add weightage to the task. So the task might be weighed heavily for history taking, and nobody would be taking the history in that correct depth and detail. They would be talking about the management, which is only a small component. So be very careful, and often the clue is in the scenario itself. So make sure that you read the scenario, and when you're reading the scenario, then you might be clear as to what's happening. Just give me a second here. I think there are people who are waiting in the waiting room, and I have not been able to add them. I'll just admit them. Okay, sorry about that. You can see the screen, right? I'm not sure. Are you able to see the screen? Okay. Are you able to see the screen, Dr. Aminat Sulfa? Can you just nod your head? Yeah, perfect. Thank you. All right. Okay. I've turned mute because obviously, people are in different environment and they've got a lot of noise and it just interferes with everybody's experience. So I've turned it all mute. Okay. The other thing is that what we're going to do after the cluster and after the time management is we're going to go through the examiner checklist. What makes you pass the exam? What does it mean by, having a structured and focused approach, clear communication that we've talked about, how to actually break down the diagnosis and differentials, obviously talk about the management plan and how to remain empathetic throughout that conversation, and make sure that you're not leaving the patient with any doubt and the patient has got clear understanding. And what makes you fail? Because if you are non-specific, if you're going on about something which is not required, as I said, that being technical does not reward you in this examiner. You need to really explain to as if you're explaining to a 10-year-old child. And if you're not really addressing patient concern, they might be giving you subtle clues that, oh, I'm not sure. What does that mean? So when the patients are asking lots of questions, that is the way that the information is still not clear. Okay. So you need to make sure that your patient is completely at same level of understanding as you are. And obviously, safety mechanisms also important, and ignoring the complete context of the scenario. The scenario is about, abdominal pain, cholelithiasis, and you're talking about, renal colic, things like that. Okay, so last 2 minutes are important. As I said, that 2 minutes might be a bit of generosity depending on how the scenario is. But even if you put in 30 seconds to just take time, 10 seconds to summarize, give some safety signs in terms of red flags are coming back to the emergency, or coming back to the um, hospital, or coming back to the GP practice, and just making sure the patients are leaving satisfied and there's nothing doubtful remaining in their history. So what I'm going to do, I'm going to start off with some clusters. We'll do some scenarios. And for each scenario, we'll go through examiner checklist. And the reason I've actually started to incorporate examiner checklist is I was talking to one of the friend who's an emergency physician who is also an ex-AMC examiner. And we had a very detailed conversation about I said, like, I mean, it's the exam which has just been taught, it's very difficult. And he said it's not very difficult. If you look at our checklist, it's quite straightforward, and those checklist boxes are about simple thing. It's never a complicated diagnosis or complicated issue. It's about the basics. So I thought it would be a good thing to talk about the examiner checklist with related to each and every scenario, so that you you understand how the scenarios are marked. So I'm going to start off with the um, cluster of dizziness, because in one of the recent exam, there's a lot of um, dizzy case scenarios are coming in, and it's often something which can be very complicated. So, whenever you're dealing with a patient who's presented with dizziness or giddiness or lightheadedness, you need to make sure that you ask certain questions, and these questions can be broadly divided into onset and nature and duration of the pattern. And obviously, as I said, before you even think about these symptomatology or these fractions, you need to have a clear understanding about what your patient has got. Meaning, in the 2 minutes that you've actually read the scenario, you should have a very clear understanding of what's wrong with your patient. So you can focus on these clusters in a very specific manner. Remain specific early on, and then as a sign of exclusion, you can go and put in a more broad spin at the end in the last 15 or 20 seconds. But try be as much specific as you can. So, for example, for any dizziness, even when I'm seeing a patient in a hospital, when did it start? Okay, was sudden, because suddenness involves, sudden things are vascular. We have all read about it. Sudden strokes, cerebellar TIA, cerebellar stroke, cerebral beat. What were you doing at the time? Was there any postural component to it? For example, if the patient's stooping forward or the patient is getting up or out of the bed, these are how most of these scenarios are organized. For example, if the patient is standing up from the bed, the examiner wants you to think that the patient was in a lying position and now the patient is standing up. And if you're able to take a clue on this one, that means that you're dealing with postural dizziness and postural hypotension as a cause of that dizziness. So use that clues, and you can get those clues by yourself by asking those pertinent questions. What about the nature of dizziness? Historically, is the room spinning or is it dizzy? I mean, previously they were used to say that is the room spinning or you feel that you're spinning. To be honest, I'm not sure about how to interpret that. Sometimes the patient can be quite confused and they would say yes to both the situation. To keep it very simple in a context, do you have a spinning sensation or you feel giddy, meaning that if you're standing up, you feel as if you're going to pass out? Trust me, these are the two questions which have helped me tremendously in my practical life as well. When they say that it's spinning, I automatically understand we're talking about vertigo. When they say, no, no, if I stand up and I feel lightheaded or dizzy or giddy or whatever term that you use, that means that their blood pressure is dropping down posturally. Okay. And obviously, the other thing is if you feel faint and off balance, now you can feel faint and off balance with both vertigo or lightheadedness, but if you're feeling faint, then it's most likely related to postural component. Now, the other thing is how long did it last? Is it constant or intermittent? This is sort of a risk assessment that as a pattern, because if it's happening all the time when he's standing up, that means that there's some medication at play. That means that he has got poor cardiac output because he's got an underlying cardiovascular. He may have, a long-term diabetic autonomic neuropathy. That means the vessels are not, constricting to push the blood towards the cerebral areas to maintain the perfusion. So having this three areas will, trust me, help you a lot. It's not a lot. And when I'll show you the examiner checklist, this is exactly what they're looking for. Trust me, for a dizziness patient, they would be looking for these simple questions, which any final year medical students can ask. Everybody clear on that one? Good. All right. So I'll move on with a case. We're continuing now in terms of triggers, associated symptoms, and risk assessment. So this is not rocket science. This is very simple. The important thing which I've told you before is already covered in the previous slide. This is something that you have to quickly go through. That look, does it occur when standing, turning in bed, bending over? You're basically confirming now what you've established with the broad question. Then the associated symptom. Is it causing blurring or double vision? That means that you're dealing specifically with occipital stroke. You're trying to localize the lesion. Is it causing auditory symptoms, tinnitus, earfulness, meaning Meniere's disease, or there could be any other inner ear problem, any headache, weakness, numbness, again, stroke type symptoms, cardiovascular palpitation, chest pain, breathlessness, meaning the patient's heart failure. He's got a poor cardiac output or reduced ejection fraction. So these things are important because whenever there's reduced ejection fraction or then there is dilated cardiomyopathy, which some of these patients do, they are risk prone to arrhythmias. Make sense? All right. And then obviously, if they're dehydrated, then they may have some nausea, vomiting, and diarrhea. Now, all of these symptoms are good, excellent. But what does it mean for the patient? Is it causing him to have frequent falls? Because this is exactly what is going to tell you if the patient needs to be admitted, if the patients can be discharged, is it an emergency? Is it an outpatient management thingy? So just be specific at the end in terms of what I call risk assessment. What does this mean to you? How is this changing your life? How do you feel that you are a different person now because of this? Are you really feeling that you're unsafe because you live by yourself and you've had a couple of falls and you've broken your wrist or whatever it is? Just take up on that. So affecting daily functioning. Okay. Now, I'm going to jump in and do like past medical history. Obviously, it's important. And especially in the past medical history, it's important to check the neurologic as well as cardiovascular, as well as medication and alcohol. These are very specific cluster based question. And as I said, be specific early on. Now, people often ask me that, oh, Dr. Rizwan, this is a lot of information. How do we get this all out in less than 6 minutes? It's practice, my friends. When you practice, trust me, you will not miss anything. You may find it's very difficult right now, but trust me, when you've practiced it a few times, it will float like anything. None of this comes naturally. I'm obviously now working as a doctor for about 20 years now. So these things they become second nature. Why? Because they're practice based. Okay. So look, I'll just do the scenario just to see how it all pans out in the terms of what we've discussed. So there's a patient called Mrs. Margaret Dawson. She's a 72-year-old woman who presents with dizziness, presents after having a dizzy spell this morning while bending to collect the laundry. Now, this is important, as I said before. And then it was followed by an unwitnessed fall. She reports no loss of consciousness, no injuries, and no focal neurological cardiac symptoms. Similar mild dizzy episodes occurred 2 to 3 times previously. Okay. But that time did not have any falls. Her history included hypertension. She's on atenolol. It also included hypercholesteremia. She's on simvastatin for that. She lives alone and previously declined aged care assessment. Her vitals are blood pressure of 108 by 66, heart rate of 56. Please pay attention here. Blood sugar level of 5.8 and oxygen saturation level of 100% and temperature is 36.7, which is normal. Now, the tasks are take a focus history regarding her dizziness and fall and explain the likely causes of the fall to the patient in simple terms. Now, if you look at it at face value, this is a very simple scenario. And if you because we've just gone through the cluster, you can see and read the scenario. And you can almost feel the links between those questions, those specific cluster-based question, and how this scenario has been engineered. And trust me, this is a scenario, if you know and you've been following the recalls, was asked in, I think, March or last month. So this is a very common dizziness scenario in general medicine. So what I'm going to do is I might just hang on, just give me a second, guys. I might just unmute you as long as if there's not too much disturbance in your background. And when I might unmute you, then just make sure that there's not much disturbance. If there is, just mute yourself because I think it'll be in the interest. So I might just questions anybody who would want to talk about it, what questions they may ask with this particular scenario. Anybody who would like to volunteer? It's not that I'm putting you on a hot seat. I just want to explore some questions. I'm the only one doing this scenario. There's no one helping me out, so I would not be able to have a look at chat box, unfortunately. So if you want to speak, just speak it out. Okay, Dr. Aminat Sulfa, you can.
Yes.
Yes, thank you. What questions, what kind of questions would you ask?
So I want to know before the dizziness comes, is there any warning signs such as does she have any heart racing, or does she have any like darkening of her vision? If she
So,
has like any chest pains, any
yeah,
shortness of breath.
yeah. So basically, you're talking about, as we thought about. So this is the problem which we get a lot. Like, there's so much disturbance. So please mute yourself if there's disturbance, if there's interface. It's an educational session. We want everybody to experience good session. There are about nearly 100 of you here. So please just be mindful. Yes, so basically what we're talking about is characterization of dizziness first. Remember that
Yeah.
three broad headings. So characterization, exactly what happened, what triggers it. Okay.
Yeah.
So
Yeah.
everything about dizziness, how does it look like? Um, how does it feel like? Okay. And then we'll take it from there. So I think starting off with, can you please I always say that whenever you're starting with a history question, start off with only 30 minutes of chance to give patients to give the history. Can you please tell me what brings you to the hospital? I believe that you've been experiencing some dizzy spells. Just tell me what's going on in here. I think this is very powerful tool here, because when you get patient to narrate, they will tell you exactly what happened. Is it a spinning sensation? How long they've been experiencing it, and have they had similar kind of episodes before, or have they lost consciousness? Have they had any falls? So all of that characterization, and after that you can dig in. You can say, oh, that makes perfect sense. Can you tell me any other associated symptoms like chest pain or palpitations, or did you feel numb anywhere? And were you able to, get up when you had a fall? Have you been getting dehydrated because you might be having some diarrhea or vomiting? Have you been unwell in any way with any infective symptoms? Or have you had any recently medications which have been changed? Have you been known to have any cardiology conditions that you've been following up with the cardiologist? So give patient an option and then target with your specific question. And remember the third thing that we were talking about? We were talking about that functional impact. Very important. So, how is it affecting you in terms of day to day functioning? Have you had falls before? Do you live by yourself? Do you feel unsafe? So, in the first minute or so, you have established what is triggering it, what is it defined by, what is it associated with, and functional decapacitation, which means the patient may need to be admitted. Correct? So that's very good, Dr. Amna. Anything else that you'd like to ask the patient? I think you're mute now. I'm sorry. You can unmute yourself? No. Okay. I don't know why you can't unmute yourself, because I did not certainly change this setting. Um, okay. Allow a participant to unmute themselves. Okay. So you should be able to unmute yourself if you like.
Yes.
Okay.
Now I can.
Yeah.
Yeah.
Thank you. Sorry about that.
It's all right. Okay. So
So my question was that, remember when I was saying that characterization, associated features, and the functional impact. This will help you gauge your discussion after you've asked the patient openly, tell me why have you come to the hospital? What led you to come to the hospital? Okay. And okay, the next thing which I might ask you, that what things in past medical history, now some of the things we've already talked about, what things in past medical history is specific to the dizziness would you like to ask Dr. M?
medication. She's on atenolol. So is she
Yeah,
taking? Yeah.
yeah,
What medications she is taking?
yeah.
And is she compliant with the medication?
Okay,
When was it started?
wonderful. Anything else?
Uh, Regarding medication?
No, regarding past medical history, medications, all of that. So
Oh,
now we're going
okay.
other phase of the history taking, which is past medical history, medication
Mhm.
history, allergies. Remember, you have to really ask the history in its completion. This
Yeah.
scenario, if I'd say, would be, somewhat um, weighted. About 70% would be in history and
Mm.
30% would be in the explanation bit to the patient. So yes, you have said medication. Anything
Mhm.
else?
So how long has she been hypertensive?
Okay, all right. So history of hypertension, very important.
How well is it controlled?
Very good. Yes.
And her cholesterol, how well is it is controlled?
Okay, that's again a very good point. Now, these are very good points. I think they're very important points as well. But Dr. Jagdeep might have some more insights to share. So we'll get Dr. Jagdeep to see what he will ask in past medical history, past medication history, and social history. How would he approach this?
Yes, and I would like to ask her since how long she has been taking this medication,
Yeah.
and is there any chance she might be living alone? She might have taken the medicine twice, maybe. So,
Yeah. Very good point. Some of these patients could have cognitive issues. So I think it's important to check up on that. Now, I'll make it simple for you guys. Whenever you go into the past medical history or medication history, you remember your history organization in your mind. Now, I understand some of you may not have practiced for a while, but remember your history taking scheme. You go and talk about the presenting complaint, history of present illness, then you come to the past medical history. Okay? So think about the things in the past medical history first, like cardiovascular condition. Has she got any history of cardiac failure with a reduced ejection fraction? Has she got any history of atrial fibrillation or any other supraventricular arrhythmia? Has she got any other history of heart blocks, which might be very relevant for this patient? Has she got history of diabetes? Okay, because that may, so do not just ask question for a specific reason. When I'm asking about arrhythmia, I'm specifically trying to picture and position those arrhythmias with postural dizziness. Correct? When I'm asking about diabetes, I'm trying to factor that it might be causing the autonomic vascular incompetence. So the blood pressure is such that it's not perfusing the brain. So how long have you had diabetes? Is it well controlled? Have you had your recent surveillance monitoring HbA1c? There, I mean, there's so many people around us who are diabetic, and these are the very important and very basic questions. And as Dr. Jagdeep was saying that when it comes to the medication, ask about if she might have taken the medication twice. Is she compliant with the medication, as Dr. Amnath said? Also, instead of going through the specific question up and down, just say, has there been any changes to the medication? Do you think that there might be some medication errors? All right. Try keep your question, and this is very important, guys. I want you to focus on that. Try keep questions very generic, as in try to get the patient to speak more. So when you want to ask about medication dose up, medication dose, has there been any changes to the dosage of medications? So that will cover both up and downs. Instead of asking two questions, that will save you time. Okay. Can you tell me something about your diabetes? Okay. Can you tell me something about your diabetes? How well controlled, how poorly controlled it is. So try be around it, but be more generic so the patient can speak more. Also, one very important thing, what kind of medication apart from the diabetic medication and antihypertensive and rate control medication would be very relevant for a patient who's presented with dizziness? Anyone? And this
ACE inhibitors,
is
Diuretics?
so
diuretics.
yeah, they are very important. That's good. But I'm talking about not the antihypertensive or diuretic medication, but any other class of medication apart from ACE inhibitors, diuretics, cardiovascular medication, rate control medication, diabetic medication, any other medication classification that
And
you
anticoagulants?
anticoagulants. That's also very important, but slightly more away from the mainstream medications.
Maybe antipsychotics.
So I was talking more specifically about sedatives. Like, is the patient on sleeping pills? Is the patient on any benzo for anxiety? Any medication to control the mood stabilization, lithium, or any antidepressant? These are important, guys, because the side effect of these medications are dizziness. The side effect of these medications are prolonged sedation if they've especially taken more dose of they've gone up in terms of their dosage of medication. So just be careful that there is a significant emphasis given in this particular scenario. And that's why lots of people fail this scenario, despite the fact it looked very easy, because they were not thorough enough. So we've talked about characterization, we've talked about associated symptoms, and we've talked about how was the functional impact in social context. Now, this is very important. And then we've talked about the past medical history. We've talked about the medication review, and we've focused it down that it could be the atenolol which might be causing the trouble in this patient. Okay. Now, um, what about the functional assessment side of things? We've not touched on yet. Anybody would like to ask how would you approach the functional side of thing? That thing that we were talking about, risk assessment, functionality. Is the patient safe to go home? Where are you going to put the patient in? Um, Anybody would like to have a go at that? All right. So, functional assessment point of view, we're talking about, um, you know, uh, we basically talking about if the patient lives by herself, if the patient has had many falls in the last couple of weeks. What else? Is the patient has had any vision deterioration? Does she use any hearing aids? Has she got an access to what we call vita call? These are all very important because she might be in a nursing home, she might be in an independent villa, in a facilitated aged care facility, or she might be living independently. But I think these kind of questions really show and demonstrate that you know how the system works. If the patient is a nursing home, then it could be one-on-one nursing home or one-two nursing home. If the patient is an independent villa, that means that she has gotten access to what I call just in case if there's an emergency. Otherwise, she's cooking, cleaning by herself. So it's important to get that kind of characterization about the independence living. Has she been having more and more uh, falls because of dizziness, and how safe or unsafe does she feel in regards to that? Okay, does it make sense, guys? Good, 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 good. We'll just move on. So, just a quick sort of now you will see a lot of terminology saying ACAT assessment. Now, ACAT assessment is, just to highlight those of you who may not know it, it's an aged care assessment for the patients who are above 80, uh, mostly above 80, or physiologically they are considered geriatric patients. And that's their functional assessment. That's their social capacity assessment. So I don't want you to go and sit the exam using those abbreviation of ACAT, but you can say, have you had any geriatric assessment by the outreach nurses or any geriatrician? Okay, because you've been having more and more falls. You might be using some mobility aids, which you're not using for some reason. You might have been seen by occupational therapists. You see, these are very important questions. And if you ask them, then it really demonstrates to the examiner that you're doing very well. Okay, so these are strong qualifier questions. Now, systems review, briefly, we can touch base, which we've already talked about, any orthopnea, edema, if we're thinking about the cardiovascular heart failure, any neurologic symptoms in terms of Parkinson's, in which there's, gait imbalance, trembling, like shuffling gait and pill rolling tremors. And if there's any ENT condition having tinnitus or ear discharge, that's also very important. And generally, if the patient is dehydrated, they may have lost some weight. So just touch base on that. Okay. So now comes the time. So I've actually written down the statement just because if I thought that if I get everyone to explained. So when it comes to explanation of the patient, that's where it hits home. And I think this is where we particularly struggle as a doctor to explain. We'll say, oh, you've got postural hypotension. Everybody knows that he's got postural hypotension. But how do you explain? Remember about that clear communication? You're explaining to a 10-year-old. You cannot say to a 10-year-old that you've got postural hypotension. You have to be really very descriptive in a layman term to tell them what's happening. So remember what's wrong with you, why is it happening to you, and what's going to happen next. These are the three things which I want you to think about whenever you're explaining the patient about their diagnosis. Now, you may say, oh, Dr. Rizwan, why are you talking about these three different questions? When the question is only about explaining the diagnosis to the patient, why are you explaining what's going to happen to them or what the management would be? Because that's how you make the concept understood. Okay. So you have to go and cover the basics fundamentals of the management. Okay. You don't have to go in detail. So very easily, I've written down here that look, it sounds like you've had a drop in your blood pressure when you bend down. Now, this is a condition called postural hypotension, and that might have caused your dizziness. And I think that could be one of the reasons that you've been having these frequent falls. And remember, when we were looking at the vital signs, the blood pressure, I kept it a little bit low. There might be some postural components in that blood pressure. So pay attention to that. So the blood pressure was low when standing, meaning that there's some postural component to it. And that is most likely related to your blood pressure medication. Now, the patients are not actually good at remembering names of the medication. So when you say, oh, it's your atenolol to blame, they may not register it immediately. So as I said again, keep it generic. Oh, this is related to your pressure medication, one of the medication which is called atenolol. Now you're making sense. Okay. And you know, then you can sort of highlight because of the blood pressure medication atenolol, one of the side effect of that medication is this slows down the heart rate. And because of that slowing of the heart rate, it's causing that lack of cardiac output because you may have an underlying condition which is dependent on tachycardia. Well, I'm not going to say, I'm explaining to you now, which is dependent on tachycardia to maintain the cardiac output. But that medication is not causing. How do you explain to the patient? Well, you don't have to go to that depth. You can just say, one of the medication for controlling the blood pressure is atenolol, and that's not getting your heart to function properly. And that might be causing the problems that you're experiencing, dizziness and frequent falls. Perfect. Saves time, said everything, tick the box in examiner checklist. And we're going to have a look at the examiner checklist next, guys. So you'll really appreciate what my friend who's an AMC examiner were talking about. Why did there were quite a few patients, doctors who actually failed this very simple dizziness station. Now, as I said, you have to talk about a little bit about what's going to happen next. Okay. And good way of thinking about it, what's going to happen next in terms of next 1 hour in one line and over one day if you're admitting the patient. Okay. So just try to lock that thought into your mind. So what's going to happen in the next hour? We'll do some blood tests, we'll do the ECG, and then we'll refer you a cardiologist or aged care physician or general physician, or we'll admit you to the hospital so they can have a more thorough look, making sure that your blood pressure remains stable. Okay. And, we may have to get some social workers and some occupational therapists to make sure that, we've got mobility aids and they've taught you how to stand up so that it does not happen again. Now, everybody clear on that? Wonderful. Now, tell me, with this kind of information, do you think it would be challenging to pass that station? You've not said anything different. You've just been a little bit more organized and structured to come to that. Okay. So just very important that you need to be um, use a simple language. Okay. Now there is something which I said before is red flags. Remember that? So sometimes before closing your arguments, it's often good to check those red flags. Have you had a fall leading to a head injury? Did you pass out? Have you been having any focal, have you been having any paresthesia, numbness, or any weakness? Have you been having any tinnitus or buzzing in your ear? Have you been having any, tinnitus, ringing in your ears? So these are linked with different differential. Now, when we're doing cluster, guys, be very careful. If I'm teaching you right now postural dizziness, this very same scenario with a little bit of modification could be of that for Meniere syndrome, could be that of an acoustic neuroma. All right. So just make sure that in the cluster of dizziness, you make a list of at least 3 or 4 differential that you can quickly exclude. Now, it doesn't matter that you exclude them at the beginning or at the end, but just do consider this diagnosis, because there's no points if you're not able to diagnose what was obviously an acoustic neuroma and the patient was going on and on about, oh, I have got this terrible tinnitus, and you'll be getting confused and you'll be saying, oh, no, no, it's all postural. No, no, it's not postural related to tinnitus. So remember those buzzwords linked to the specific diagnosis. Okay. Now, let's go and focus on postural dizziness. Just as a quick summary, I've made a list of various medication which I think are important, like furosemide, beta blocker, ACE inhibitor, dicyclic antidepressants, levodopa, dopaminergic agent. Then volume depletion is very important. Autonomic dysfunction we've talked about related to diabetic autonomic neuropathy. Spinal cord injury. Look, I don't think you will get asked or presented with a question of spinal cord injury presenting as postural dizziness, but this is just one of those lists which I had to put the causes. But the cardiovascular are important. Bradyarrhythmias, tachyarrhythmias, heart failure with reduced ejection fraction, valvular heart disease in which there's severe amount of mitral regurg. Okay, deconditioning. For example, the patients may have an underlying malignancy or something like that. And endocrine cases that you should also consider is hypothyroidism and hyperpituitarism. Okay, so just to put everything into the context, guys. All right. Now, these are the other differentials that you must consider. I don't need to go into the details of that. We've already talked about that. So just make sure that you've got a strong list of differential. Now, remember I was telling you about the OSCE examiner checklist. Like, what are the components that the examiners have there on their list to make sure they pass you or fail you? So, needless to say, you're able to introduce yourself, you're able to confirm the identity of the patient. Now, you may all have a very good formulas to go through that. Just make sure that in the heat of the moment, you're able to practice that with every patient. You are empathetic, you're listening. Remember, open up with a broad question. Let them speak first, and then pepper them with more specific questions. Okay? And guys, I'm going to say it over and over again. Make AMC Clinical simple. You're complicating it for yourself. It's not a complicated exam. It's a simple exam. Try talk to the patients as if they're, 10-year-olds. Trust me, you will never go wrong. And your confidence will improve. Just, and also for the context, they're not medically literate there. So they are as much overwhelmed as you are, the actors who are doing the exam. And obviously, consenting is important before any sort of history and explanation. So have a very clearly defined introduction, but try not. Sometimes I listen to the participant. My name is this, and can you tell me your name and are you comfortable right now? And just try not go on a spiel of quickness. Try take your time. Okay, okay, Mrs. Rawson, you've come in here with some dizziness. I'm sorry to hear that. Would you like to tell me how your day been so far? Just clarify with a little bit more of an individualistic approach. Okay. Have at least 2 or 3 intros so you can flip between the patients. Okay. Then look at that. Focus history taking. Type of dizziness. We all established that. Onset, duration, triggers. We've all established that. Associated symptoms. Circumstances of fall. Now that's crucial. If somebody would have missed the fall, they would have failed the station and they would say, oh, I asked everything. Okay, cardiac, neurological, ENT screens are important. Medications are very important. Okay, functional status is very important. Living arrangement and support. And remember in the scenario, she refused age care assessment before. So acknowledging why she refused it. Okay. And then clinical reasoning when you're coming to your diagnosis that it's orthostatic hypotension because of atenolol. Have you really broken it down and presented to the patient in a very simple way and explaining to the patient as if it's simple, clear, 10-year-old? Okay. And then management plan. You're given a little bit of management plan. Now, even though it might not be a component that has been asked, but I think it's good to give them an initial management plan, like what's going to happen in one hour and what's going to happen in one day. So that puts everything, when you go to the hospital yourself, you're always anxious about what's going to happen next. Just imagine that the patients are going through the same mindset. So it's you reassuring what you feel yourself. And then lastly, my friend was saying the professionalism is something which really lacks. And these are doctors who are not really working, and or they might be working in a different field. Like sometimes you get anxious, your structure is not, you're repetitive, you're very time conscious, and you might be speaking very fast. It does not look good, guys. You need to be very calm and collective throughout, no matter what happens. Remember, it's an easy exam. You're only making it difficult for yourself. And summarize findings. As I said, summary is important and give them a safety net mechanism. And remember how bad the station goes. Thank the patient. All right. It's very important to have leave on a high note as opposed to a low note. Okay. Now, what I might do is let me just bring it up. Okay. I'm going to do another scenario which I've made for you guys. It's on abdominal pain, very common again. And I think this is something which people look, literally, I've used the examples where people often think they're easy, but often these are the ones which have got higher qualifiers. You have to really be very specific and be very careful. So let's talk about this scenario, this cluster, and then we'll do the scenario. I think Dr. Amanath has got a question. Yes, Dr. Amanath, what's your question?
Yes, doctor, like I know like about being specific about like certain differentials, but can we just when it come to, for example, medication history, like can we ask like do you take any medication or do we have to be specific by and in this question like some medications are given and do we need to confirm like she taking these medicines? I mean, and also what about the rest of the medication? Can we just generally ask are you on any other medication?
Yeah, that's a very good question. Look, I'll reproduce one very good example. When I was doing my exam, I got given by a very senior examiner. That's often good to ask the patient, and I still do that in my practical life. What medication do you take related to your heart or your diabetes? Okay. And can you tell me if there's been any changes? So you can make a very quick statement and let them, or can you tell me what medications that you're on? Now, the actors themselves are trained to give you only the information which is relevant for your clinical scenario. Okay. They're not there to give you unnecessary details, confusing details. They're meant to be giving you details because they're triggered. They will, the examiner will not take your argument of postural hypotension or postural bradycardia unless and until you ask about the medication. So even if you trigger that with what medications you're on, the actor will exactly tell you what medications they've been on and how they're going with that medication. Yes, you can subclassify that any changes. So, as I said, my examiner told me a very good trick. What medications are you on, in particular related to your heart or diabetes problem, because they're very relevant to this condition? And has there been any changes? And then you can make a subtext that anything else you'd like to tell me. This is a very powerful question. Anything else you'd like to tell me about your medication? I think at the end of every segment of the history of present illness, anything else would you like to tell me about your complaints? Anything else you'd like to tell me about your medications? Anything else you'd like to tell me about your social circumstances? It is giving the patient an opportunity of something that you may have missed. Okay. Does that answer your question?
Yes, and also when it comes to like diseases, do we need to ask like, do you have any heart condition rather than saying AF and
Yeah, yeah, absolutely. Heart conditions, just be a little bit more specific because there could be number of heart conditions, in particular heart failure and arrhythmia, or any valvular problems, because these are the, it takes less than 10 seconds, right? You're not going to just go on and on about, further subclass one. Take less than a second. Just spit it out there. Okay. All right. Now, abdominal pain history cluster. Now, obviously, the patient presented with pain. Everybody know about the pain cluster of Socrates. Stick to that, guys. It'll save you time. It'll save you effort. Just go through your Socrates. Site, onset, character, radiation, any associated symptoms of that abdominal pain, timing, and then, relieving and aggravating factors, and severity out of 10. Now, that's very important when you're checking on severity, because if you check on severity, you might be able to give the patient medication to get them comfortable. Because if you're really forgetting about getting them comfortable, the patient will not be very open. Okay. Now, as I said, when you're taking the history, the first question, what should be the first question?
What brought you to the hospital?
Yes, exactly. Well done. What brought you to the hospital? And then you can further subclassify with your cluster. Okay. Try get them to say the specific things so you save your time down the line. Okay. So start off with that. Now, the other thing is, which is very important in this abdominal pain cluster, is that we often forget about associated symptoms. So, guys, don't forget about the associated symptoms, gastrointestinal symptoms, urinary symptoms. If the patient's female, about gynae and OB symptoms, and systemic signs of, fever, chills, now weight loss. These are the constitutional signs of infection and malignancy. So do ask them. Okay, don't forget that. Now, um, same goes with the past medical history. Any past medical history, any past medication history, any social history. And then when you're doing the examination, make a comment on the appearance of the patient. Because you might be doing an abdominal assessment in terms of examination. This patient's coming with abdominal pain. He's got an obviously palpable lump in the right groin. It might be a, inguinal hernia. It might be femoral hernia. It could be umbilical hernia patient. Just make a comment on that. Okay. If the patient is distressed, if the patient's looking pale, sweating, obviously exam patients are not going to demonstrate those signs of pallor and sweating, but you can say the patient was initially distressed and had to be given some analgesia and now is much more comfortable. All right. And often it's a good technique to be 100% honest and truthful. Say what you see. The exam is face to face now. You'll have lots of normal patients. Don't cloud your judgment with the scenario. Okay? Say what you see. If the patient has got a hernia, you can come and talk about the hernia. If the patient has got, rash, talk about the rash. If the patient looks jaundiced, talk about the jaundice. Don't make signs which you may feel are relevant to the patient based on the scenario. In examination scenario, you have to be very careful not to let go. And you may have real patients as well. As AMC on their website have said that you may have real patients, you may have actors. Okay. And then, yes, important thing is vitals. Just make sure that you always ask about the vitals. Now, okay, abdominal examination. I won't go into the details of that, but just make sure that when you simple things, inspection, palpation, percussion, and specific signs are important. Now, these are the signs which are in the examination's checklist. So again, a very simple thing to miss out. But trust me, if you've missed something in terms of gallstones, but you check for the Murphy signs in the examination, you might still salvage and prevent yourself from failing that station. Because what you lacked in history taking, you have compensated from the examination. So just be careful of remembering these key signs. Okay, there are about 4 or 5 signs. Just make sure you practice them. Obviously, you can't do the internal examination or intimate examination in exam setting, but do mention. And there's no point in just mentioning, I'll do the rectal exam. Say I'll do a rectal exam to feel for any blood on the glove, any masses, or any degree of tenderness which may suggest anal fissure, hemorrhoids, or any rectal malignancy. So the examiner knows what you're thinking and why were you doing that exam. Okay. Same goes with the pelvic exam. Same goes with the testicular exam. Give them the reason. Okay. Now we'll do a quick scenario. There's a patient who's a 50-year-old gentleman by the name of Daniel Harris who's come to the emergency department with sudden onset of right-sided back pain that began 2 hours ago when he was at work. The pain is sharp, intermittent, and radiates to his right side of his abdomen. There is no history of trauma, no fevers, and he's got a past medical history of hypertension, which is managed with Ramipril. He has 10 pack year smoking history. He's got a vital signs of blood pressure of 138 by 86, slightly tachycardic at 98. He's got respiratory rate of 18. He's saturating normally on room air, and he's afebrile at 36.5 degrees Celsius. Now, my tasks are to take a focus history, do a focus physical examination, or maybe you can ask. I don't think that this scenario would be that long. It would be that take a focus history and ask for the physical examination from the examiner and then explain the diagnosis. Okay. So predominantly, again, this would be divided somewhere around, somewhere around 40, 30, and 20, something like that. Okay. Or 50, 30, and 20. That would be the marking schema for something like that. Okay. So let's go. Now, just looking at that scenario, what are some of the differentials are going through your minds? Anybody?
Renal colic,
Yes, very good. Renal colic. Anything
then
else?
pancreatitis, acute pancreatitis, because is it radiating towards the back? Maybe it is a radiating pain or towards the back.
Yeah,
It
yeah.
can be
Pancreatitis,
pyelonephritis, but we
pyelonephritis.
need to rule out about the fever.
Yeah.
And the other thing is that trauma. It can be any trauma to the
Mhm.
abdomen. It um,
Now,
it
guys,
can be appendicitis
yeah,
and rapid
look,
pain.
I'll just stop you there, doctor. I think these
No
are
history of trauma.
very, very good thoughts, but this is exactly what you do not right. You're just giving me everything which could happen to any abdomen. Now, I've given you a very specific scenario. And if you look at it, there's only two possibilities which are most obvious, but then the list, yes, can be exhaustive, which would become very clear. Now, I don't think the AMC will ever give you a pyelonephritis without a temperature or a fever. All right. So try to read the clues to your advantages. That's the point which I'm trying to say. Okay. So if you're not reading the clues, you're not saving yourself time. You're wasting your time. Okay. Does it make sense? So again, tell me, what would you think of? Can you all see the scenario right now?
Yes,
Yes,
doctor.
Tom.
Yes.
Yes,
Ureteric
doctor.
calculi. Yes, we've talked
Calculate.
about. Yes, very good. What else? There's one very, very typical thing which,
Slipped disc.
what's that? Sorry?
Slipped disc.
Slip disc. Now,
I
yeah, I
couldn't
mean,
it
that
be
is,
a
yeah, it is.
gallstone that's passing through the common bile duct right now, causing the pain in the right quadrant?
That could be a good possibility as well. Excellent. Yes. All right.
Rupture of an aortic aneurysm.
Okay.
Aortic.
Yeah, that's a very good thought. Now, let me
The
just,
patient wouldn't be vitally stable, no?
okay, I'll stop you there. Now, somebody just said ruptured aortic aneurysm. Guys, you got to be very careful here because I was talking to one of the junior medical officer on my last shift just this Friday. And she was an intern and she said, oh, it could be a ruptured aneurysm. So remember, there is no such patient which exists with ruptured aneurysm. They are dead. They're called dead bodies. All right. So if somebody's got a ruptured aneurysm, you won't have a blood pressure. You don't have very unlikely to have a conscious patient. So ruptured has got a very high mortality. So what you're trying to say is a dissection. There's a fundamental difference between an aortic dissection and an aortic rupture. Now, that's completely fine. I used to make the same mistake, and still, the University of New South Wales and Sydney University people tend to make the same mistakes. That's completely all right, but that mistakes must stop now. Please don't use the terminology of rupture aortic aneurysm if the patient's got blood pressure, if the patient is conscious, because by definition, it's a life threatening, time critical condition. And I don't think that a ruptured triple A has ever been put in an AMC scenario. Okay, so as much as it's important, try to be more be specific. Aortic dissection, very important. And that's actually a very good point. And that's what that doctor was trying to say. Because this patient is 50, he has got a history of smoking, he's on Remipil, and he's got hypertension. If you look at the demographical risk factor for AAA, this is a classic patient for a aortic dissection. I'm making the same mistake. Aortic dissection. Okay. So the only two valid differential diagnoses here would be an aortic dissection and ureteric colic. And then, yes, there's a list is exhaustive. It could be a gallbladder pathology. It could be a discitis of some sort. It could be osteoarthritis or radiculopathy from disc prolapse. But that's unlikely. The AMC wants you to think very specifically into the two main pathologies and then have at least three or four pathologies to be excluded. And you're going to do that, all right? Remember, it's just not about the AMC exam. That's how all the exams are done in this professional world of medicine. Okay? They want you to think specifically about only two or three things, and then they want you to think about in terms of quick rule outs about three or four things. And nobody's trying to trick you. If anybody's trying to trick you here, it's yourself. So, again, coming back to my opening statement, keep it simple for yourself, guys. Okay? Now, anybody who would like to have a go as what would be the key historical features is specific to this scenario's two main working differential of ureteric colic and abdominal aortic aneurysm, what would you like to ask the patient? Anyone? We're all friends here. There's no right and wrong answer. I think if you say that here, you won't forget it for the rest of your life.
If I'm suspecting a ureteric calculi, I know this is a little far-fetched, but I would like to ask the patient whether he has any hematuria, because
Mm-hmm.
ureteric calculi could cause that.
Mm-hmm. Mm-hmm. That's a very good point. It's it is far-fetched because majority of the time it's a microscopic hematuria with predominant bladder pathologies. You would get macroscopic hematuria. So just be very clear about what you're choosing. And I know that, look, some of you may not have seen enough patients with renal colic, but remember there's a difference between the macro and micro. If it's macro, it could be a renal mass, malignancy, or it could be a bladder mass, stone, or malignancy. Okay? Or even cystitis. So, good point, but just be careful. Anything, again, starting, you've given the patient an option, the patient has already directed your mind to very particular two conditions, that is aortic dissection and renal colic. What else would you pepper him with? That's the word I like to use. Pepper him with, built up on his knowledge to get yourself maximum marks. Come on, you can do it. Come on, tell me.
Sir,
For
I'll tell you one example. It's
whether
often
the
again
patient has a history of vomiting and
it's
history of burning maturation. I would
very
like
good,
to ask for
very
renal
good,
colics.
excellent. So,
symptoms
guys,
of LUTs
diseases,
basically.
yeah, diseases which happen, they happen frequently. So this actor would have been programmed to say that, look, you've had similar kind of episodes before, but you're not to volunteer this information. It's only when they ask you, because renal colics are recurrent. If you have seen a kidney stone patient in your hospital, they may give you an information, it has happened to me before. At least 50% of the patients that I've seen with a renal colic, they will come with a recurrence of the same problem over and over again. So has it happened before? Previous similar episode. What was the level of intervention? Did you have a stent put in, like a ureteric stent? Okay. Or do you feel the symptoms are somewhat similar to your previous kidney stone? Okay. Remember, when you're talking to the patient, you're talking to a layman. So give them a layman term. The stone, previous kidney stone, even though the stone might be in ureterics, area, say kidney stone, because that's a common terminology. Correct? Now, other important thing, as somebody said, hematuria is very important. It does not differentiate between, if it's a big stone, it may even cause hematuria. It might be some urethritis which might cause hematuria, but microscopic hematuria, there might be some associated fever, there might be some associated dysuria. Some of the patients get that. So do get. And once you've, like, I mean, when I am documenting the history of the ureteric colic in an emergency department, I see the patient is presented with the typical symptoms of, right-sided flank to groin radiating pain. The pain was initially excruciating and responded to fentanyl and morphine. The patient had an evidence of microscopic hematuria. The patient also has had previous stones which were stented before, and the stents were removed, and the patient has got no fever to suggest there's an obstructive calculus causing septic problem, or the patient has got normal kidney function test. So that would be my thought process. I'm just putting my thought process out. In terms of history, you can also talk about the past surgeries, like if the patient has had any past kidney surgery, any bladder surgery. These are very, again, specific to this scenario. What if the patient has had any vascular surgery? He's a vascular path. That makes you think about the aortic dissection side of things. The other thing is, what the patient had a sudden onset of pain. So aortic dissection happens suddenly, and it goes front to the back, back to the front, goes up into the chest, goes. If it's not making sense, the pain is all over the shop, it's an aortic dissection until proven otherwise. I remember I was working once in one of this very busy Sydney hospital, and I had a patient in his early 50s, and he had an aortic dissection pretty much from the ascending aorta all the way to the arch to the descending aorta, and he was just sitting there with his head in his hands. And no matter how much morphine I was giving him, he was just not getting comfortable. So aortic dissection can have this pain which just does not settle until and unless you do something about it. Okay. And so important, past medication history, non-steroidal, steroidal, anticoagulation, medication history are important. Family history, renal colics, bowel cancer, these are all hereditary. There could be tendency of, having them in their immediate family relatives. So do explore them. And if there's been any travel history, sometimes I've seen patients who've been dehydrated because they were traveling overseas. They also get presentation of renal colics. So just be careful there as well, guys. Good, good, good. Now let's go more forward. How am I stuck here now? Hang on. Okay. Can you see the screen? No, neither can I.
No.
Some reason my screen is also gone. Can you see the screen now?
Yes, sir.
Okay, fine. All right. Okay. Now I can't see you, but I can see the screen. All right. So, yeah,
Dr. Rizwan, just another question. So, like you said, vitals for every patient, get the vitals. But is it in the beginning, or can we do it like if the patient is like we feel like he's not stable, or like in the examination?
look, when the vitals are normally given in the AMC clinical scenario, if they're not given in the AMC clinic, you can just do a quick screen check, especially with the conditions of an abdominal syndromes. It's often good to have the vitals early on, because you may find, oh, the blood pressure is like 70 systolic, and you only discovered that when the station, you've only got 2 minutes left. Now it completely changed, is it just completely changes the whole scenario. Okay. So just make sure with critical diagnosis leading to that, just make sure that you ask these questions early on related to vitals. Okay.
So like I mean like it wastes a little bit of time like if we ask for every scenario, but like depending on the scenario we can ask, or like do you recommend
Exactly.
ask?
Yeah. So look, I mean, some of the scenarios are about counseling, right? And they're more about the management of the patient who has got some pain, but he's alert and oriented. It doesn't look like the patient's unwell. If the scenario points to the, and that is very important, there is nothing which is written in book, but if the patient AMC wants you to think about the patient is unstable, trust me, the scenario will sound like the patient is presenting with severe pain. He looks pale and diaphoretic. He is not looking well. He is distressed. So if these are the telltale sign, you must ask the vitals early on. Or you can have quick check, is the patient stable? I'd like to proceed. Okay.
All right, thank you.
That was a good question. So again, we've talked about the focus history. We've talked about the associated symptoms and exclusion. Yes, guys, don't forget about smoking and alcohol history. And obviously, the other important things is about if you're there to ask the questions, then these are the questions that you must be asking about. You know, are there any scars? Is there any presence of distension? Is there any specific tendon, especially in the flank or lower abdomen? If you're thinking about the aortic dissection, then you'd ask about the pulses, like if the pulses on the right side of the body are equal to the left side of the body. Okay. And ask the examiner whether, what is the genital examination if it's relevant to your scenario, and what's the bladder distension like. Correct? All right. Now, moving on. Yeah, it's giving me a bit of a trouble, my screen. Okay. Okay, fine. Just give me a second, okay? All right, sorry about that, guys. Where were we? Okay. And now, the other thing that we were talking about is, what are the basic investigation? There are only two things when the patient are about 50 and you're suspecting a renal colic. Urine test for a dipstick, you check for the blood, and imaging. CTKUB is pretty much standard. You don't tend to do an ultrasound now these days, mainly because the fact ultrasound does not actually picks up the stone, first of all. But you can do an ultrasound if the patient is pregnant and you're suspecting that they have got a stone and they may show some hydronephrosis. Or the other strong differential is pyelonephritis, for which the ultrasound is a lot more sensitive. And you cannot do CTKUB because obviously of the exposure of radiation. Now, it might not, the scenario is related to the management, explaining the diagnosis. Just give me a second. All right. Okay. Okay. Now, where is my slideshow? Okay, that's fine. Then let's talk about the examiner checklist. It introduces, you've done your introduction. Again, empathy, active listening, and respecting the patient's thought. You don't ever have to disregard patient, no matter how ridiculous they may sound. And obviously taking the consent. Now, in terms of this particular case, it's important to ask about the things that we've already established: dysuria, hematuria, frequency, any bowel changes, any fevers, which may suggest an urgency to that matter. And screens for the red flags. That's very important. Previous renal colics, which may have required stents, any underlying abdominal aortic aneurysm. Now, remember the patient may have an aneurysm, not the aneurysm rupture. Aneurysm could be there. And sometimes aneurysm may get a dissection, or aortic dissection can happen without the aneurysm as well. There's an important classification that you must understand. You will not get a scenario of aortic aneurysm rupture in exam but you may get a scenario related to an abdominal aortic aneurysm or aortic dissection, which can happen with or without aneurysm. I hope it makes sense. It's a bit of a repetition, but it makes sense. Okay. And then, examiners were also thinking about social history, smoking, alcohol, hydration, and, clarifies whether it's a first time or recurrent, because some of these things can happen repeatedly. Now, physical examination points, obviously, it's important in terms of inspection, palpation, checking the pulses, obviously checking for the signs of peritonism, and checking for the renal angle tenderness. That's also very important. And obviously, as I said, with the intimate examination, whenever you wanted to do that examination, mention that. Why you want to do that examination. Just not saying that I would like to do a rectal examination. That does not mean anything, guys. You have to be specific. I'd like to do a rectal examination, check for masses, check for blood in the glove, and check for any hemorrhoids, internal or external. That tells the examiner and get you the full marks there. So you need to get the full marks. Okay. And lastly, when you're explaining your diagnosis, this is a patient with renal colic. Unfortunately, not many people were able to pass this. They might not have failed this exam or scenario because they were not able to pick up the renal colic. They might have failed the scenario because they were not talking enough about the aortic dissection as a rule out. They did not exclude the other nasty diagnoses in terms of gallbladder pathology or appendicitis or hernia as a rule out. So guys, again, coming back to the same point, it's very important. The scenarios are very obvious from the presentation, but it's important to rule in and rule out the important differentials there whilst being specific. So these were some of the differentials which we got. And then there was another thing which I found very interesting, is that explanation to the patient that use very simple terminology. It is a stone which is irritating your tube connecting the kidney to the bladder. And most likely, I often tell my patients that it is stone which was previously living in the kidney, but it's now trying to come out, which is a natural progression. And because it's passing through the narrow tube connecting the kidney to the bladder, that's why it's causing this intense pain and irritation. And then, you have to reassure the patients how many stones do get operated. No, like more than 2/3 of the stones pass out on their by themselves. So mention it to them that this stone will pass out based on its size. Obviously, if the stone is like, more than 8 mm, you can't say that it will pass out on its own. But the stone is small, then yes, it will pass on its own. And then talk about, as I said, talk about the things that you're going to do in 1 hour and in 1 day, including any complications. And then give the patient an opportunity to ask questions. Make sense, guys? And then the last thing which the examiners are always looking for is that, unhurried approach, being logical, not being repetitive, very clearly thought out, structured response. And even though you might say that it sounds very well articulated because you've got X number of time here, it's not about the time, it's about the practice. Trust me, when you do renal colic scenario with the differential of AAA and gallbladder, you're actually creating or preparing for 5 pathologies at the same time. And it's only the practice which will get you there. Do it 2 or 3 times and you can't go wrong. Correct? All right. I think that we'll stop here, guys. I think I've got many different scenarios.